Thank you. Good afternoon, ladies and gentlemen. On behalf of my colleagues back in Cape Town from the Department of Health, City Health and IHI, I'll be presenting this afternoon the implementation scale-up of the Art Adherence Club model in the Cape Metro from 2011 till 2015. So, we all know the background. We know that there's been tremendous scale-up of art provision over the last 10 years. We know that retention over time is decreasing. And as we've heard at this conference, we now know that patients need to start treatment on diagnosis, which will vastly increase the demand on our art services. So, if we don't want our art services to totally collapse, we're going to have to do things slightly differently. We need to find alternative models of care for art delivery for our stable patients. And those models need to serve three purposes. Firstly, they need to better cater for the needs of stable patients. Secondly, they need to decongest our facilities so that our clinicians can spend time with the new patients and the patients that are failing treatment. And lastly, they need to feasibly be able to be scaled up quickly. The club model is a model that we think can do these three things. It was piloted by MSF with the Department of Health in Khayelitsha, Cape Town. It's a quick service option for groups of stable patients. So instead of the individual patient spending half or a full day in the clinic, seeing the clinician and queuing in the pharmacy for their art refill, we now have groups of patients who meet 5 times a year and are led by a lay healthcare worker. They don't pick up their files, they don't attend individual adherence counseling sessions. They meet for 45 minutes where they have a short peer support session and they receive their pre-packed ARVs. They're seen once a year by a clinician for clinical review or through the model referral mechanisms if they become unwell. They're also entitled to send a family member or friend to attend the club to collect their treatment if they can't make it themselves. This model was shown to be very effective, and for that reason, the Cape Metro, the Department of Health, decided to partner with MSF and IHI to scale it out in the province. So let's talk a little bit about this Cape Metro that I keep referring to. It's the district in and around Cape Town, South Africa. We now have 130,000 patients on treatment in this district at 70 art sites. We describe in this study the scale-up of the model from January 2011 to March 2015, only using routine Department of Health art monitoring data. And these are our results. So in this graph, you can see in the gray the increase in the number of art facilities in the Cape Metro. In the red, you can see the number of those art facilities offering art adherence clubs. By the end of March 2015, 77% of the facilities were offering clubs. But perhaps more importantly, only 6% of the total art cohort were sitting at facilities that didn't offer clubs. These are mostly new art facilities with small cohorts. In this graph, you'll see the increase in the number of patients accessing their care through the club model. By the end of March 2015, we had 32,500 patients in clubs in the Cape Metro. That accounts for 25% of the entire cohort. And how did we do this? One of the main reasons is that facilities were able to take the model and adapt it to suit their specific context. And so we see a lot of model variation at various facilities across the metro. In the left-hand side of this table, you'll see the components of the model that have been adapted by facilities. In the right-hand side, you'll see the types of adaptations that have been made. So the Department of Health took the approach to issue very broad guidelines for implementation, setting out minimum eligibility criteria to enroll in a club, but making sure that there was enough space for adaptation for facilities that had more resources to be able to roll out clubs more quickly. In this table, you'll see how those changes to eligibility criteria have changed over this period. So when we started, we said that patients needed to be on art for 18 months before they could qualify for a club. The beginning of this year, we changed that to 6 months. When we started, we said patients with comorbidities could not be in the club model. This year, we've said that patients who have controlled diabetes or controlled hypertension can be considered for an adapted version of the club model. Not all of our facilities, however, are able to utilize the full guidelines because of resource constraints. And so many of our facilities are still only allowing enrollment at 12 months because they just don't have the capacity to run any more clubs. And I'll talk a little bit about that later. On the opposite side, we do have facilities that have more resources, perhaps because of a partnership with an NGO. In these facilities, we see adaptations to the model for specific need groups. So we have clubs that are for family units, we have clubs that are for youth, and we now have just started clubs for only men. We see facilities that have strong community health worker networks around their facility or relations with community-based organizations, and they've used those to move their clubs out of the art facility and into community venues closer to patients' homes, and in some cases into patients' homes. So let's go back to the data. In this graph, we're seeing exactly the same data as we were looking at before. This is the increase in the ART cohort over time. So as you can see, 4.5 years ago, we had just on 65,000 people on treatments in the metro. We now have close to 130. In the grey, you'll see the increase in the number that are receiving their care through a clinic-based system, and in the red, those receiving their care through the club system. When we look at the growth in club care in the context of the growth in the total cohort, it looks far less impressive. And why is that? Well, essentially, over 4 years, the ART cohort has doubled in size. They've taken on an extra 60,000 patients in care. Transitioning patients into the club model has only offset 51% of that increase. Over the last 3 years, we've not been able to move above 50%, and that's because we've been limited to leveraging existing human resources. So despite a growing ART cohort, there have been no more management capacity, no more human resources added to either model of care. So the club model has been great because essentially it's optimized every single efficiency that there possibly was, but now we've exhausted that. And unless we start providing resources into both of these models, further growth will be constrained. And as we're already seeing, our quality of care will suffer. So in conclusion, the Cape Metro over 4 years has been able to transition 25% of its cohort into clubs. It's effectively implemented a simplified model of care which demedicalizes HIV care and ART supply for our stable patients. The rapid expansion shows that scale-up is feasible and acceptable to both healthcare workers and patients. The flexibility in the model has led to model variations as facilities have changed it to suit their context. But the growth that we've seen to date is under threat if we're limited to leveraging existing resources. They're now exhausted. From our implementation experience, we make the following recommendations. Firstly, that adaptable alternative models of care for ART delivery, such as clubs, should be considered for broad implementation. In South Africa, the National Department has now endorsed the club model for rollout in South Africa. It's already started in other provinces. But it's important that the simplicity and the flexibility of these types of models mean that they can be adapted for different contexts outside of South Africa, contexts with more resource constraints or system constraints. Two enablers, though, are detrimental to their success. The first is a reliable drug supply. While in the Cape Metro, we have a very well-managed drug supply, we see throughout the region drug stockouts. These put all of our models of care at risk, but specifically community-based models, where community members are waiting for their ART refills outside of facilities. Secondly, we need an enabling regulatory framework. In many of the countries around sub-Saharan Africa, we have pharmaceutical and nursing regulatory frameworks that are blocking implementation of these types of models. They have rules around who can dispense, who can hand out tablets, how long scripting periods should be, and how long art supply can be provided. And these need to be renegotiated if we're going to maximize the use of these models of care. And lastly, in the context of a growing art cohort, these types of models are resource efficient, but they are not free. These are still our patients, and we still need to make sure that the models of care through which they receive their treatment are funded. Thank you.
Thank you so much, Lynn.